Thank you. Some of you know me, but some of you don't. My name's Saul Wilson, just like Dr. Deloy said. I'm one of the neurosurgeons at the University of Iowa. That's me. This is an old picture. Still looked good back then. So I did 2 fellowships, one in pediatric neurosurgery, one in vascular neurosurgery, and I've done lots of different things like Dr. Deloy said. And years ago, it's been a while now, I took over one of my partner's practice. He took care of a lot of the pain patients, a lot of the spasticity patients. I inherited that practice, so I've been doing it for many years now. And so when I heard about this conference, I thought, I know exactly what I want to talk about. So we're talking about pain and treatment of pain for spinal cord syrinx. Some of these patients have lots of problems and not many options, so I thought maybe there's an option for some patients, so we're going to talk about that. So for the objectives for this, we'll talk about the pathophysiology and the clinical presentation of a spinal cord syrinx. We'll talk about some medical management. We'll discuss some of the surgical options, including spinal cord stimulation, and we'll discuss risk of the procedure, limitations, and outcomes. Okay, so Dr. Deloy gave an amazing talk. I loved it, actually. And so some of the things I was going to talk about, he already went over. So I won't spend a lot of time talking about, things that are associated with the spinal cord syrinx, like a Chiari malformation, of course, trauma, tumors. That was an amazing tumor and outcome. I thought that was very impressive. Tethered cord and idiopathic, sometimes with a syrinx, we don't really know why. And so Dr. Levy's talk, while he was giving it, also a great talk talking about the pathophysiology behind the formation of a syrinx. This is amazing. So I won't spend too much time on this because we've already gone through it, but there are a few different theories as far as how does a syrinx form. And just like Dr. Levy was kind of explaining, sometimes you get fluid going into the cord from the vasculature. The central canal, has bulk flow of fluid. Okay, let's go back here one. And then fluids absorbed by veins inside the cord. That's normal pathology. In the abnormal state, according to this theory, there is a change in the compliance of the veins. The veins aren't as distensible. Because of that, fluid builds up inside the spinal cord. That continued pressure leads to essentially rupture into the parenchyma of the cord, and you get this extra canalicular syrinx. Okay, so again, like I said, many different theories as far as how a syrinx forms. This is just what Dr. Lee was talking about a few minutes before the presentation stopped. This change in flow, you can get scarring or some sort of blockage of flow. That CSF pulse gets transmitted into the cord itself. You get expansion of the syrinx, and you have the pathology associated with the syrinx. Okay, again, same thing as discussed previously. Typical presentation, cape-like sensory loss, reflex changes, spasticity, weakness, and pain. Okay, so there's a lot of other symptoms, but this is what I see most frequently. So pain is really what we're going to kind of focus on. Sometimes that pain's neuropathic pain, burning, electric, tingling, just annoying type of pain. So before we talk about the treatment, we're going to try just understand the anatomy of pain. So this is just kind of a mock-up of a person and their spinal cord with a few cross-sectional images corresponding to the mid-thoracic cord, the lower thoracic cord. This is actually below the cord at the lumbar spine, and then way down at the very bottom at in the sacrum. Okay, so and just so you kind of understand this cross-sectional view. So we're around here, we're blowing that up. We're looking at it right here. Okay, so this is the front part of the cord. Here's the back part of the cord. Here's what we call the anterior horn. We have a lot of the motor neurons that control motor function, okay? And here's the dorsal horn, where we focus on sensory function and, for our purposes, pain, okay? Now, this is a simplified view of how pain is transmitted from the periphery up to the brain. So we have a sensory nerve. We have lots of the cell bodies of that sensory nerve that goes into the cord, okay? There's a small neuron here. It projects across the cord and up the cord into the brain where there's conscious perception of pain. This is a very simplified version of reality, okay? All right, slightly more complex. Same thing, sensory information is coming into the cord. Here's some cell bodies for that sensory information. Goes into the cord. Here's that projection neuron going up to the brain. But in addition to that, we see the brainstem itself sending inhibitory signals down into the cord. Some of these are sent through serotonergic neurons, some of these through noradrenergic neurons. The focus on this portion of the cord here, this second layer of the back part of the cord, this dorsal horn, this substantia gelatinosa, this is where kind of the focus is on what's going on with pain. What's happening here is the brainstem is sending inhibitory signals down to this area here. This area could potentially promote or maybe decrease pain. So that's where a lot of stuff's happening, where the signals are happening, okay? So again, even more complex. This is actually not reality. This is a simplified version of reality, but this is the gate theory of pain, okay? So you can think of painful information is coming in through those sensory fibers, and it can go through to a projection neuron and go up, ascending the spinal cord into the brain. Simple, okay? But here is an inhibitory neuron that basically can slow down those painful signals, bing, 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 stopping the painful information from going up to the brain. As I said before, this is getting signals from the brainstem coming down. It's also getting signals from other peripheral nerves, bringing in information as far as vibration, temperature, and some pain. So basically everything is focusing on these inhibitory neurons, and they can either let painful signals go up to the brain or maybe not. So that's normal, okay? All right. So no pretty pictures, but we're talking about the pathophysiology of pain. What's going on, okay? And I think Dr. Libb was kind of talking about this a bit. There can be some disrupting of those ascending fibers, okay? That dorsal horn where all that stuff was going on, we can have some increased excitation, neurons more active. You can have some active inflammation in that area, or you can have pressure from the spinal cord syrinx. All that stuff's happening, compressing and changing the function of the dorsal horn, leading to pain. Okay, so how do we treat it? Now, again, we talked about some of these things already. Simply, if you have a Chiari malformation and it's symptomatic and there's obviously signs of progressive syrinx, you treat it surgically with a post-false decompression. Nothing fancy about that. Plus or minus duroplasty, depending, typically duroplasty. If you have a cord syrinx from other lesions, you might do a duroplasty. These procedures here, a syringo-subarachnoid shunt and a syringopleural shunt, I consider those maybe second-tier interventions. They're, from my standpoint, a bit more invasive, maybe less predictable results. And so just like Dr. Deloy said, I thought, and again, before you start doing something like that, you may think, what's going on, okay? So anyway, for all these surgical procedures, the goal is to restore normal spinal fluid flow, decompress the cord, reduce the syrinx size. Okay, now this is what this is not the meat of the presentation, but I really got excited about this because I see patients, not all, but some of them have really painful symptoms. I wonder, why is that? What's going on here? What's going on? Okay, so this is not a new paper, older paper, but it shows a cross-sectional image of a syrinx, a very simple version of a syrinx, and just fluid right in the middle of the cord. That's fine, okay? This is one, we have a syrinx that is enlarged. It's filling up the entire cord. In this particular case, this is the back part, the dorsal horn involves the dorsal horn, okay? And then whenever I see something like this, I'm like, what's going on here? This syrinx has kind of an irregular appearance. This deviated type, again, involves the dorsal horn of the cord. So what's interesting about this is when you look at these patients in their preoperative pain, when you see these people, these deviated syrinxes, all of them essentially have pain, okay? This normal configuration, no pain. So this kind of points to involvement of that dorsal horn leading to painful symptoms. Okay, this is a nice paper as well on a little bit of a different standpoint as far as duration of symptoms before treatment. And so you think, gosh, I have this problem? When should I get it taken care of? Should I put it off a bit or maybe get it squared away? According to this, for people with pain and no pain, the people with a longer duration of disease, 30 months or so, they have pain. In general, people with no pain, shorter duration of disease. Okay? And then when you talk about people who improve or don't improve with interventions in general, this is for post-faucet decompression for a person with a syrinx. The people who don't improve have a longer duration of disease before they're treated. So to me, it says two things. One, that dorsal horn is important when it comes to pain. And two, not doing anything and waiting could lead to maybe a lack of improvement. Okay. And so again, back to that deviated syrinx. Okay. And so when you look at the people who had surgery and did not get better, look at them. Deviated syrinx, enlarged syrinx, deviated syrinx. These people who wind up having no post-op improvement, that's who they are. Okay. So I don't always see this, but when I see an image like this, I think, oof, that might be a problem. And usually it is. Usually it is. Okay. This is not always a problem, but sometimes it is. Okay. Now, this shows a nice little mock-up image. Again, so you see, the normal pathways, everything's intact with this syrinx that's central, but when you have this deviated or enlarged syrinx, it disrupts all that normal anatomy we just talked about, all the descending inhibition and everything. Okay. So just a bit of medical management, obviously, criteria for observation, stable imaging findings, minimal symptoms, obviously, okay. I'm not going to talk a lot about rehab, but it actually is pretty important, and I see some long regimens for rehab, and I think, does that matter? Actually, it does. It can help even with the pain, and then now we'll talk about some pain management strategies. And again, so like I said, Dr. Deloy said, I'm one of the neurosurgeons here, so I'm not constantly prescribing pain, but I do see some of these patients, and what are they taking when they're being treated for pain? Well, a lot of times, Neurontin, okay. And a lot of times Lyrica, and it has some symptoms, some sedation, some dizziness, depending on the dose. So some people say, this is great, I love it. Some people say, you know what, not so much for me. Not as frequently. I see people on Alevil, some tricyclic antidepressants. Again, they have some side effects with those medications. And then less frequently, I see patients on serotonin and norepinephrine reuptake inhibitors, antidepressant medications. But if you remember, that descending inhibition from the brainstem was coming down to the cord, supplying norepinephrine and serotonin. And so with these medications, maybe you're increasing the amount of those neurotransmitters into the cord, maybe improving pain. Some second-tier therapies, so I take care of a lot of the pain patients for other reasons, and occasionally I see them on lidocaine patches. They have some variable benefits. Some people like them, some people don't. When it comes to a spinal cord syrinx, occasionally I see people on opioids. I think, probably not going to work, so it's really not a recommended medication, although some people are on it. And then I mentioned physical therapy and other things. Cognitive behavioral therapy, I was really looking into the literature to find something on that. Couldn't find anything for spinal cord syrinx, but actually I think, there's something to this. And at one point, we had someone who was really excited about it here at University of Iowa. She left, but I think that's something that, we really ought to think about. Okay, now, even less frequent interventions, and I don't see any my patients getting this, but occasionally I see some of the patients for headaches. They are admitted to the hospital for ketamine infusions, and I can't tell how well they work, but, according to our just anatomy pathway, it may make a difference. When it comes to THC, that's not something I really know a ton about, but from what I do know, the issue is going to be delivery of a constant dose. So whatever you get, you might get a higher dose or a lower dose. Typically, when I get a constant steady dose, and where you're going to get that is kind of up in the air. So no good recommendation from me on that. Okay, now to the surgical treatment. Two surgical treatments I don't love for a spinal cord syrinx. Dorsal injury zone lesions, DRES lesions, they're not done so frequently now. That dorsal horn that I mentioned before, you can lesion it basically and maybe get pain relief. The downside is that's an ablative procedure. It's an invasive procedure, and so it's not very frequently done. Occasionally, you might have someone with intractable pain that go to that, but typically not. Intrathecal drugs, the typical medication in the pump is morphine and opiate, so not ideal, so not very frequently used, okay? But spinal cord stimulation, it can be used, it has been used, but it's not very frequent. And the reason that this came to mind for this presentation is I was talking to a patient, I thought, you're a good candidate for this. I was thinking in my mind, and they were so afraid of the procedure, they wouldn't even consider it. I thought, oh, geez. And so I wanted to show this, say, hey, it's not so bad. If it works for you, it's not so bad. Okay, so what are the steps leading up to getting that intervention? Well, a psychological evaluation. If you have untreated anxiety, untreated depression, this is not going to work very well, so you want to get that taken care of first. You'll get a trial done where you have a lead placed, and you have maybe 3 to 7 days of a trial and see how it goes. The lead's placed in the epidural space, and it's placed if you have a spinal cord syrinx in the neighborhood of the syrinx. Okay, if you get more than 50% pain reduction, you could go into a permanent implant. Oh, I think I might have deleted a slide. Oh, okay, no, I do have more slides coming. Okay, so this is just some images of the lead placement. So I wanted to show this because the patient I was talking to was just so concerned about this. And I think compared to other things we do, posterior fossa decompression, laminectomy, duroplasty, this surgery is tiny, small. May or may not work, but at least the trial portion of it, not very big. So under X-ray guidance, this is a person lying face down on the table. Here's a machine shooting X-rays, just giving some local anesthetic. Okay. After you get some local anesthetic, use X-ray guidance to find an appropriate entry point for a needle that goes into the epidural space, the space that's above the dura. Use what's called a loss of resistance technique. You pass the needle, you have a syringe filled with air or fluid, you tap on the syringe. As the needle goes in, you can feel some loss of resistance, indicating you're in the epidural space. Pretty consistently, you can get in the right spot. After you do that, you thread this lead into the spinal canal, and you put it at the appropriate spot, test the patient. That's it for the trial, okay? Now, again, I've had some patients come to me, they're so worried about the battery pack for the permanent implant. Oh my gosh, terrible. But this, as time has gone by, these batteries have gotten smaller and smaller and smaller to the point now where you can implant them, and you really, if your normal body habit is, you don't really see them very much. They're not very big. And this actually is not even the most recent one. There's a new one that's even smaller than this. So for those implants, we'll implant a pulse generator. We'll anchor the leads, we'll optimize stimulation, and then typically it's an outpatient procedure. It takes a couple hours, okay? So here's a case, and again, if you look at the literature, you see just a case here, a case there. It's not, it's not frequently done. And then whenever it comes up, I say, hey, you might think about this. There's a lot of shock when it comes to it because, people will get a decompression, but, this is too much, apparently. So this is a patient with a spinal cord syrinx, a Chiari malformation. She had surgery. She got better. The syrinx got smaller. Big, small, okay? Big to small. And she got pain relief. Good for her, okay? 10 months after surgery, pain flared up again, and a spinal cord stimulator was planned, okay? Now, in this particular case, they use an entry point in the lower thoracic spine. They thread these leads right up to the cervical spinal cord, and they used fast-acting subperception therapy, okay? So I'm mentioning that because there's different ways to stimulate the cord. Traditional stimulation is maybe 100 hertz, 100 little stimuli per second, and depending on the company, they might have different little paradigms. In this particular case, higher frequency or this subthreshold stimulation was helpful for the patient. So either higher frequency or subthreshold frequency or different little paradigms might make better results. But the bottom line is this person got better. And the result was durable, okay? And so immediately afterwards, this will focus on the VSS pain score. Immediately after implant, pain is improved. You might say it's a slight uptick, but in general, long duration pain relief for this person. Not perfect pain relief, just improvement, okay? So contraindications. Let's see. Let's go to this one here. Poor surgical candidate. So, because people think, gosh, can I do this? So, if you've had a tumor and you've had a laminectomy, bone removal, and then the dura opened and the dura closed and the bone replaced or maybe not replaced, there's going to be too much scar in there to do this at all. It's out. And so you can't do it for that. If you had spinal trauma and you have spinal stenosis where the canal is just too narrow, can't do it then, okay? So those, I look at those images and I was like, can't do it there. Some people will be more aggressive. I think, no, probably not. So when I put this here, poor surgical candidate meant, elderly person with lots of medical issues, but really there are certain anatomic configurations, if you had things done that might really out. For example, if you had a syringo to subretinal shunt and you've had things open up there, probably you maybe can get a stimulator, but probably not. The scarring might block you, basically. Okay. Obviously, infections, blood thinners, psychiatric issues, and then when it comes to ability to operate the device, the way I think about it is, if you can work a cell phone, then you can manage this. You'll be fine. Now, risks. Here's the big one: spinal cord injury. That's not a good one. And so I think that scares people. Typically for that lower thoracic entry point, T12, L1, and you're doing a percutaneous lead placement with that little needle that I showed there, the risk of that is, I wouldn't say zero, but very, very, very low, okay? Now, for some implants, I'll have one of my colleagues from our pain team do a high entry point, maybe lower thoracic spine, T3, T4, a little bit high risk there, but still low risk overall. But spinal cord injury is kind of the big thing. With these percutaneous leads, the risk is low, but obviously not zero. There's some other configurations where I think the risk goes up, I wouldn't say quite a bit, but definitely goes up. But the percutaneous implants, low risk. Lead migration. So you get this lead in, and it's in just the right place. Everything's great. If you wiggle around, move too much, again, the lead moves, it's no good. So typically for the first few weeks or so afterwards, you kind of let things settle down. Infection, hematoma, spinal fluid leak, those things can happen, but if you can minimize those with technique, okay? Hardware, late risks, I think the big one is maybe loss of efficacy. So I showed you that data from maybe after a year, and you see patients in general with this, you see them, not everyone has sustained results. Maybe about half the patients, after a couple of years still can't get good results, but still, that's a pretty good, decent number. Scar tissue formation, I mentioned that here, but really for the percutaneous leads, the scar is not terribly intense. There's another configuration where you open and put a pad lead in there. You get a lot more scarring, but not as much with the percutaneous leads, okay? So for outcomes, there's limited evidence, but it's growing. You can see every once in a while another person with a case report or a case somewhere, and so you'll see these things out there. I think the mental hump to get over that, it's kind of large sometimes for the patients, and I guess sometimes for the providers too, but you can get reduction in pain, improvement in quality of life, and decreased pain medication use. Okay, but obviously you've got to select patients carefully. Okay, so just to summarize everything, just for a spinal cord syrinx, that's symptomatic. Decompression surgery is typically the mainstay in the appropriate management, and there are medical management options out there, pain medications, oral medications. They're sometimes effective and ought to be done first before you start considering, any more invasive procedures. And then the key thing is this dorsal horn. That's where all this stuff is happening. When you have an abnormality of the dorsal horn, you think, what's going on there? And then you start thinking about other treatment options. And then finally, just to wrap it up, spinal cord stimulator offers an option for some patients that might be helpful to get maybe a long-term reduction in the pain. Okay, and with that, I'll wrap up for any questions. Thank you.